Hello guys, welcome back to my channel. In today's video we're going to talk about antiepileptic drug called phenytoin. It's also known as dilantin. So the purpose of this video is to point out how phenytoin can be used in anesthesia, its special consideration, and how it interacts with other drugs. So to first begin, phenytoin, also called phenytoin sodium, can be given IV, which is more interesting in anesthesia, and also oral IM. So phenytoin is gonna act, its mechanism of action is gonna block the sodium channel into your brain. By blocking those sodium channel, phenytoin is gonna decrease the neuronal excitability, and that's how it acts to help in seizures. So what is the anesthesia indication of phenytoin? Phenytoin can be used in three main ways in anesthesia. So if you have a patient going through status epilepticus, phenytoin can be used like as a second line agent. What do I mean by second line agent is that phenytoin is going to decrease the risk of recurrence of seizure, not treating it, but decreasing the recurrence. Now, the agent that are going to stop the seizure during status epilepticus, you can give lorazepam, diazepam IVs, and midazolam IM. So phenytoin is going to be a second line agent for those status epilepticus patients. You can also give phenytoin to treat ventricular dysrhythmia. Remember, phenytoin is an class 1B anti-arrhythmic drug, so it can be used also in digoxin toxicity. I did upload a video about digoxin, and I went in depth talking about the toxicity of digoxin on the heart and how phenytoin can be used. If you haven't watched it, please do so. So phenytoin can also be used pre, intra, and post-op on the patient that have traumatic brain injury. If you want to prevent the seizure or treat the seizure during the operation, you can use phenytoin. So what is the pharmacokinetic of phenytoin? So phenytoin is very special because phenytoin is a potent CYP450 and UGG enzyme inducer. What do I mean by that? This enzyme called CYP450 is a group of enzymes that are located in the liver, and their main function is to catalyze the reaction of oxidoreduction in the liver. The UGT enzyme is also a group enzyme found in the liver, but they catalyze different reactions. Those reactions are called glucuronidation. So phenytoin is going to induce both of those enzymes. So if a drug is metabolized in the liver by those enzymes, phenytoin is going to make sure that that drug is quickly metabolized and leave your body quickly. So that's why we're going to have a lot of interactions, drug to drugs interaction with phenytoin. Also, phenytoin is also metabolized itself in the liver by those enzymes called CYP450. So if your patient has liver failure, you really want to adjust the dose of phenytoin. Phenytoin is also special because phenytoin goes through a zero order kinetic. We have zero order and first order kinetics. Zero order means it's only a constant amount of phenytoin that is excreted from the body. But first order kinetic, like most of the drug, is a constant percentage of a drug that is excreted from the body, eliminated from the body. So with phenytoin and other drugs like aspirin and also ethanol, they all gonna go through a zero order kinetic. That means the enzyme that are responsible of the metabolism can be saturated, and they only gonna eliminate a constant amount of phenytoin. Phenytoin is also highly protein bound, mainly to albumin. So if you have those patients that have hypoalbuminuria, maybe because they are kids, neonates, or maybe because they are going through some disease, or maybe because they are malnourished, It's gonna increase the fraction of unbound phenytoin, increasing the toxicity of phenytoin in those patients. And also because phenytoin is highly protein bound, it's able to displace other drugs that are highly protein bound. Just like carbamazepine is also an antiepileptic drug that is highly protein bound, so it can displace carbamazepine from the protein and increase the toxicity of carbamazepine, because remember, it's only the unbound portion of the drug that is active. Drugs like warfarin, phenytoin can displace them from the protein bound and make sure that your patient bleed. So it has a lot of interactions. We're gonna get to that. Phenytoin also is called phenytoin sodium. Is so weak as, so you don't want to give phenytoin along with other local anesthetic that are weak acid, because it can precipitate. Also, you don't want to mix phenytoin into dextrose or normal saline solution. You want to use a filter giving phenytoin. So let's touch base on the interaction with other drugs or other antiepileptic drug, anesthesia drug with phenytoin. Phenytoin has a lot of drug interaction. Mostly, if a patient is on chronic antiepileptic drug, be prepared, because your dose requirement of propofol, rocuronium, thiopentol, opioid is going to increase. So when you do your assessment and you find out that your patient is on chronic antiepileptic drug in general, this is what is going to happen. Also, if your patient is a young lady taking oral contraceptive, phenytoin is going to increase the metabolism of those oral contraceptive, and she might be pregnant. So for those patients, you want to make sure that you stay away from phenytoin, and you can actually give gabapentin. Gabapentin don't have those interaction with oral contraceptive. So phenytoin, because it's a potent inducer of CYP450 and UGT enzyme, all the other drugs that are also metabolized by those enzymes are going to be affected by phenytoin. So phenytoin is going to decrease the level of other antiepileptic drugs, just like carbamazepine, oxcarbazepine, lamotrigine, topiramate, zonisamide. So just watch out for that, because most of the time when the patients are taking antiepileptic drug, they can be on a bunch of antiepileptic drug. So you want to make sure that you watch out for that. There are three mainly drugs that I know that will increase the level of phenytoin. Phenobarbital. Phenobarbital is also an antiepileptic drug that can increase or decrease the level of phenytoin. Brivaracetam is also an antiepileptic drug of the same class as Keppra. It can increase the dose of phenytoin. And valproic acid. So I also want to mention that phenytoin is going to increase the dose of phenobarbital. Why? I don't know. Phenobarbital is also a CYP450 inducer. So phenytoin is going to increase the dose of phenobarbital. Now, let's say you're in the middle of the case and you need to give phenytoin. Maybe your patient has some kind of ventricular dysrhythmia, and your patient is also on non-depolarizing neuromuscular blocker like rocuronium, virocuronium. Given acutely, phenytoin is going to increase the effect of those non-depolarizing neuromuscular blocker. So if it's time for your patient to have the treatise and you don't see those treatise, you might know why, because of phenytoin. So these are the main interaction that I know with phenytoin. Is a bunch. The list is infinite. So these are just what I know. Now, let's talk about some side effect of phenytoin. I feel like phenytoin is good on the side effect class, because most of the side effects are dose related. So when I think about the side effect, I class them into three subcategories. So we have the dose related, the non-dose related, and the dermatologic side effect. So dose related means that the more I go up on my dose of phenytoin, the more I'm going to see those side effects. Now, what is the dose of phenytoin? Phenytoin, if you give phenytoin in, let's say you want to treat those status epilepticus, you want to give phenytoin from 16 to 20 milligram per kg. Now, keep in mind that phenytoin has a narrow therapeutic index. So, if your patient is taking chronically phenytoin, we want his blood level of phenytoin to stay between 10 to 20 mics per kg at all times. And also, if you want to give phenytoin IV infusion, you don't want to pass 50 milligram per minute. This is very important because if you give more than 50 milligram per minute, you are increasing the chances of this substance called propylene glycol to accumulate. So propylene glycol is a potent cardiac depressant. So if it accumulates, it's going to give you cardiac dysrhythmia, hypotension, bradycardia. So that's why you don't want to pass those infusion of 50 milligram per minute of phenytoin. So let's go back to our side effects. So the dose related side effect, let's say if I go over my 20 milligram per minute per kg, I'm gonna see things like ataxia, difficulty with gait. I'm gonna see like nystagmus with my eyes, and I'm also gonna see those side effects like dizziness, vertigo. So they're gonna increase the more as I go with the dose. Remember, don't pass 50 milligram per minute with phenytoin because you're going to have propylene glycol, which is going to give you bradycardia, hypotension, and cardiac dysrhythmia. So let's talk about the non-related side effect. Phenytoin is classified, it belongs to the class of hydantoin, and is susceptible to give us fatal hydantoin syndrome. So phenytoin shouldn't be given to pregnant lady because it can give you a lot of fatal abnormality, cleft lip and palate. And the fatal hydantoin syndrome is characterized by a large set of eyes, large mandible, and also fingers abnormality. So you don't want to give phenytoin to a pregnant lady. So the non-dose related, phenytoin can give you gingival hyperplasia, and it's also a side effect that you can see with your calcium channel blocker. Yes, so I did upload a wonderful video about the calcium channel blockers. If you haven't watched it, please do so. It's very interesting. So yeah, you can have gingival hyperplasia with phenytoin. You could also have hepatotoxicity with phenytoin. So if your patient have a kidney failure, please watch out on the dose of phenytoin. Adjust the dose. Phenytoin can also give you hypertrichosis when somebody start developing hair everywhere, and it's a side effect that you can also see with a drug called minoxidil. It's used for hypertension. It's a vasodilator drug. So, and also there are other side effects like GI irritation that you can see with phenytoin. Now, for the skin, for the dermatologic side effect, most of the anti-epileptic drug can give you rash. Phenytoin the rash potential is very rare as compared to this anti-epileptic drug called lamotrigine. Lamotrigine is worse at rashes. So if you see lamotrigine, think of rash. But phenytoin, you can get rash, you can get Steven-Johnson syndrome, you can get the Dread syndrome, but it's very rare. So because of all these side effects, I think that researcher or pharmacologist came with another drug called phenytoin. So phenytoin is actually a drug that acts like phenytoin, and when it gets into your body, it's cleaved into phenytoin by some enzyme, and the process of phenytoin becoming phenytoin is not interacted by any drug in that process, which is great, less interaction. Also, phenytoin can be given IM without the risk of pain. We saw that phenytoin IM can give you some pain. Phenytoin is liposoluble. Phenytoin can be given faster than phenytoin. Actually, remember you didn't want to pass 50 milligram per minute with phenytoin. You can give first phenytoin 3 times faster. So you can give first phenytoin up to 150 milligram phenytoin equivalent per minute, so 3 times faster, and you have less risk of bradycardia, hypertension, and cardiac dysrhythmia if you do so. You can also give phenytoin in status epilepticus at a dose of 15 to 20 milligram per kg. Is also highly effective. um Phenytoin is also a great drug because it's less IV irritant, so less phlebitis, and you don't need a filter, and you're saving your time by not having to restart IV over IV. So, and like I said, it's also highly effective like phenytoin, and you can give it 3 times faster than phenytoin. So guys, this is what I got for phenytoin. I didn't talk about everything that you should know, but I try to pick up the main points that can be like very useful for anesthesia. So if you have a comment, if you feel like I forgot something or anything, just drop a comment below. I love reading you guys comments, and if you haven't done so, please subscribe to my channel, share, and put a like, and I will see you on my next video. This week is mainly gonna be anti-epileptic drugs. Very interesting. Okay guys, see you.